Welcome to the third annual Liverpool Dementia and Aging Research Conference. So just as I was saying as well now, if everyone could please mute themselves. Sometimes there's some background noise, which can be a bit distracting. That'd be great. So we've got a great lineup of speakers, which I'll go in a minute. So I'm just going to share my screen now, and I'll put that on full view for you. There we go. So we've had a lot of people that have registered. We've had over 270 people registering for today, which is great. And we are also actively on social media throughout the day. So many of our speakers are on Twitter. So if you want to engage via social media as well, please feel free to use the hashtag Liverpool Dementia. We'll be on there and we'll be updating about the talks as well. And just a little bit of a run through again through the agenda. You should all have received that in your email. Hopefully it hasn't ended up in your spam folder. We've got 12 talks today, and afterwards we'll have some breakout room discussions as well. We've got a whole array of different talks coming up. For example, something on flu care and care homes. We've got something on post-stroke vision impairment, end-of-life care, also working towards a dementia-friendly community. And I think what's really nice about this array of speakers is it's not just us academics talking, but we also have a carer sharing her experiences, and we have third sector organizations and care providers sharing their work and their services, including House of Memories and the Liverpool Dementia Action Alliance. So it'll be great to hear from all of these different talks. And during the lunch break, we'll also be showing a short video, if you wanted to have your lunch at the screen, from the Manchester Camerata, and how specifically one person living with dementia has been engaging with the Manchester Camerata. Okay, so, but you should have this agenda as well. And then after lunch and after the final talks, we will have a half-an-hour breakout room discussion. There'll be 4 breakout rooms hosted by a speaker. So room 1 will look at care homes, led by Alice Griffith. Room 2 will look at social care workforce, led by myself. The third room will be focusing on family carers and any priorities or topics that might be of interest there, led by Warren Donnellan. And then the fourth room will look at inequalities and barriers in accessing care, led by Kerry Hanna. So when we come to that, around 2 o'clock today, you'll be able to pick your room, whichever you fancy most. And then there'll be a few questions that will be discussed in each of them. And then afterwards, we'll reconvene as a group. And really, that is it from me as a first welcome. If you have questions throughout the talk, please put them in the chat or raise your hand and we'll pick them up afterwards. So I think that's really the welcome introduction. So the first talk is by Alice Griffith from the University of Liverpool, and she'll be talking about flu care, estimating the effectiveness and cost effectiveness of a complex intervention to increase care home staff influenza vaccination rates. So Alice, over to you. Please feel free to share your screen.
Thank you. I'll just set that up now. There you go. Is that, can you see that okay?
That's great. And just to kind of say again, if everyone can please mute themselves. Thank you.
So I'm Alice. As Chris said, I work at the University of Liverpool as a lecturer in clinical psychology, and I'm going to talk to you today about flu care. And while lots of people today will be talking about research projects that they've done or that they have recently completed with flu care, this is something that we've just started. So I'm going to kind of show you the other side of how we prepare development of interventions and how we start out on big projects that go over a few years. So in terms of who's in the team, I'm just one of a very large group. So the co-chief investigators are Amrish and David, who are in University of East Anglia and University of Leicester. Then there's all sorts of co-investigators. So obviously I'm representing the University of Liverpool, but there's some other unis, Council, Public Health England, NHS, and a care home as well. We then have lots of people who kind of look at the flu or care home side of things. So we have Boots, who deliver a lot of vaccinations, and the National Care Forum, HC1, different kind of large care organisations. And then importantly, we have our lay advisory group, which has 8 people who are relatives of someone who lives in care homes, or have a relative who lives in a care home, or have experience of care homes in another way. And we then have 12 researchers and other staff. And this was funded by NIHR, and it was 1.4 million. So quite a large project, and it will run over 3 years. So in terms of why this is needed, we know that 17,000 people a year sadly die from flu. And it's particularly problematic for people who are living in care homes. So World Health Organization advised that 75% of care home staff have a flu vaccination to help protect residents. However, at the moment in the UK, it's only around 35% of staff who actually get this. So this led us to develop what we now call Flu Care, which is looking at what we can do to help increase that rate amongst staff. So obviously the past 18 months have been very problematic for all of us, and have shown just how important infection control and being aware of being ill yourself is. So because there was such a small amount of flu last year, there's a severe resurgence anticipated this year or next year. A lot of what we learn from Flu Care hopefully will be useful for COVID vaccinations or joint vaccinations, which are being talked about. And also people are talking about vaccines in a way that they haven't before, which gives us the opportunity to change what is normal about having a flu vaccination amongst staff. Obviously, there was also huge issues around infections and mortality in care homes through COVID. And there's been severe resistance within the sector against mandatory vaccinations. So we know that a lot of people feel strongly about not wanting to have a mandatory vaccine. But what we don't know is how we can help people uptake their vaccine. Is it that they don't want it and they're never going to have it, or are there things that we can do to help people's attitude towards vaccination change? So in terms of what's already in place to support care home staff, if you're on a contract with a care home, i.e. you're not an agency member of staff, you can have access to a free flu vaccination, and pharmacists are allowed to vaccinate staff in care homes. However, agency staff aren't entitled to a free flu vaccine through this policy, and they're the staff who are likely to be in the most different care homes. So actually it's really important that they do get their vaccine. So realistically, we're not tackling all the remaining barriers that we have to people taking a vaccine at once. So the potential impacts are, if we have less flu amongst residents, we can hopefully have improved health. If we have less flu amongst them, we can also decrease mortality and hopefully improve care continuity. So if there's less staff sickness, that means that residents can enjoy seeing the same faces every day, making sure that they're getting that continuity in who provides care for them. And also less cost to the care homes for having to use agency staff to cover staff sickness. So hopefully you can see there's positives both for residents there and for staff, and also hopefully for relatives who won't be likely to have to stay out of the care home for infection control reasons. So looking at how we developed the intervention, we've had 4 kind of major stages, because we all came together saying, actually, it's really important that we do something to make sure that people are getting the vaccines that they need to protect residents. But actually, what do we already know about what works, and what would be helpful to learn before we kind of set off on this journey? So the first thing was a systematic review of all the evidence that's out there for what supports care home staff to get a flu vaccine and what is a barrier. And that's in progress at the moment. But what that found was a real lack of UK evidence. So we don't know a lot about what's going on in the UK around flu vaccines for care staff. We then did a survey of 415 care home staff to look at why people do or don't get their vaccines, and that was around this time last year. And these are some of the reasons that people gave, which are, I was quite surprised when I saw some of them. And some of them are obviously very young members of staff, some of them are older, and they work in a range of roles across care homes. But just a few examples of why people said that they didn't get one. So someone saying it's too expensive. Well, actually, we know that they're entitled to a free flu vaccine, so that shouldn't be a barrier. People who think they're too busy, they can't afford the time off work, they just don't want to have it, they don't know where to get vaccinated, they don't think it prevents flu, it's difficult to get an appointment with the GP, they didn't think they were eligible, or people who kind of don't want vaccines in general. So someone who's described it as poison and said they wouldn't put poison in their body, and others who felt they had a natural immunity already. And my favourite response was someone who was over 65 and didn't need it because they felt they looked after themselves. So actually people have a lot of strong opinions about their vaccine, both positively and negatively. But these were some of the main reasons that helped us to decide what we needed to be focusing on in the intervention. So some of these show misinformation, misunderstanding, kind of lack of time, lack of ability to get the vaccine, but also perceptions that there may be difficulties with access to this. So what we then did with this using behavioural science techniques is mapped them to something called the theoretical domains framework, and looked at what we could do to tackle each of these issues. So that sounds very complex, but what it looks like is this. So we spoke to different members of staff and looked at different things that we thought might work. So for example, on the left, we can see in-home vaccination. So 100% of people agreed that that was affordable. 91% of people agreed that was practical. 100% of people thought that would be effective. And 91% of people thought it would be acceptable, safe, and has equity across all different types of staff. So that was felt that something we should definitely include within this intervention. Highlighting to people that it would protect not only you, but your family as well. So by getting your flu vaccine, you're protecting yourself, but actually you're also protecting those around you, not just the people in the care home where you work, but the people in your home as well. And as you can see, this one's more mixed. So some people felt very strongly that it was affordable, practical, and equitable, but they didn't feel that it would be effective so much. And they weren't sure about the safety of it, about the messaging of it, and whether actually that was a fair comment. So that was one that we took to the workshop, which I'll go over in a minute, to discuss further. The final one that I wanted to show you is an example of something that people absolutely did not agree with, which is a video of a celebrity talking about why it's important to get your flu vaccine. And this is something that we often see used in policy changes, kind of celebrities talking about why something's really important to them, but actually care home staff didn't feel that this was going to be effective and that it was a strategy we should use. The only positive for it was that it was equitable across everybody, so it wouldn't target certain groups, but people didn't feel it was acceptable, practical, or would be effective. And they didn't also think it would be affordable, which is interesting because I guess the cost would be paying someone to appear in the video, because actually sharing a video of a celebrity wouldn't really cost anything. So the final thing we did was a workshop with care home staff to look at what, which of these components we should include into the final intervention when we designed it. So here's an example of how that looked. So the issue that we were addressing is staff questioning why they should get vaccinated when other people do not. So kind of, why should I get vaccinated when other people my age don't, or other people who look like me don't. So this was an example of providing information about protecting yourself and your family. So this is the one that I showed you a minute ago in the other table. So this is the discussion that we had in the notes section. So this was people asking, are there statistics about it? Do people understand what this means? Do they understand what it means to get your vaccine to protect your family and how it might protect your family? Some people thought it could be extremely effective, that actually staff should be concerned about protecting their family from flu. But other people felt that it could be risky because actually it is a very emotional response that this creates. Like, if you don't get your vaccine, you're not protecting your family, and that might provoke backlash from people. And actually they might not respond to it positively, but might think, well, actually, are you suggesting that I don't care for my family by making this decision? And a final suggestion was to focus on vulnerable family members, thinking that people might think about it more seriously if that focus was on specific members of their family who may be particularly vulnerable to flu. So we focused on these three areas of effectiveness, acceptability, and safety, because the other areas were already approved through the survey. So what happened through all of that was we, as a group, got together and designed the following intervention. So these are the 5 barriers that we're trying to tackle. Staff say they don't have the time to get a vaccination. Some staff have to pay, as I said, agency staff. Perceived lack of need. So I'm healthy, I'm young, why do I need a flu vaccine? The others don't have their vaccination, and belief that vaccine is ineffective or it might cause flu. So this is what it looks like. It's unnecessarily complex, as all of these kinds of interventions are. So we have 3 main behaviour change techniques that we're looking at. So the first one is restructuring the physical environment. So looking at what happens in care homes. So can pharmacies come into the care homes more regularly? Can there be NHS funded flu vaccination clinics for all staff in care homes, not just agency staff? For the perceived lack of need and the fact that others don't vaccinate, we're developing videos and information materials featuring staff and residents on what the health risks are on staff non-vaccination and why it's really important from a resident perspective. And finally, we've got videos and information from GPs and people from Public Health England talking about the myths of vaccines and presenting that information in a way that is easily understood in videos and posters. On top of that, there's monitoring of uptake. So monthly care homes will be delivering their, telling us how many people have received the vaccine. And there's also financial incentives for care homes who reach a certain level of vaccination. So that's what the intervention looks like, but obviously it's incredibly complex and it's going to take a lot of unpicking as to which bits work. So the research has 4 phases. So phase 1 was what I've just covered there, refining the intervention, looking at what it might look like, working with care home staff and residents to establish what's important to them. Phase 2 is the feasibility study. So that's what we're just starting now, and with 10 care homes. And then phase 3 is a much bigger trial next year in the next flu season. And then the final phase is looking at policy development for dissemination. So hopefully in a couple of years, I'll be able to come back and talk about what we found from flu care. But what I thought might be interesting today is looking at how the other side of things work, how it looks when we're just starting a study. And as I said, we've got our fantastic lay advisory group who are providing input throughout and who have got stuck in with absolutely everything so far. So phase 1 is what I just covered. And now we know what it might look like. Our main objectives are to develop the videos. We had a bit of an issue with the film crew who had gone, who were literally on the way to a care home to do some of the filming, and the care home had a positive case of COVID in the care home, so they had to turn around and drive all the way back. And these are the sorts of things that you don't plan for when you design a study. Finalising what it might look like to have community pharmacy provision of vaccinations in the care home, and finalise what the data collection methods are going to look like. So for phase 2, what we're trying to do is look at what happens in the control arm? So what happens for care homes who don't have any of this intervention? What are they doing? What does that look like this year? Because obviously it changes every year based on what information is available, what the NHS are sharing, what CQC are sharing. There's lots of information that goes out that changes every year. And what we want to do is look at what the outcome data collection is like, what works from getting this data from care homes whilst things are still so strange and we can't do a lot of face-to-face data collection, and look at how we can improve how many people the intervention reaches within the care homes that we're doing this in. So for the feasibility study, we've got 10 care homes. So we've got a nice mix of nursing and residential, smaller and larger ones, privately owned ones versus ones that are owned by a charity. And we haven't got any local authority ones. And we have got some who are part of small organisations and larger organisations. So they've got, they're allocated to one of 5 options. So number 1 is just do what you're going to do anyway, and we'll ask you at the end what happened this winter. Number 2 is do what you're going to do anyway, but we'll ask you every month how many people have had their vaccination. Number 3 is having the information materials that I talked about, so the posters and the videos, and we'll ask you at the end what happened. Number 4 is the information with regular monitoring. And number 5 is having absolutely everything. So having the clinics, the information materials, and regular monitoring. And then, because often in these kinds of studies, where we find the interesting bit is by going in and observing what happens, because that's where you tend to get a lot of your information. So we've got all sorts of things in what's called the process evaluation, where the researchers will follow the care homes over time to really understand what happened for them and why they got the outcomes that they did. And then, as I said, next year, we'll be looking at 70 care homes across Norfolk, London and Leicester, and 35 will have the intervention and 35 will have the control. And we'll be looking at care home staff vaccination rate again. And then similarly, we'll have a process evaluation looking at interviewing different people, trying to understand what the care homes look like and looking at whether they met each of the different outcomes. We've also got, so the cost effectiveness bit is health economics, looking at how much does it cost each care home to have a 1% increase in vaccination rate. So how much would it cost the NHS or the social care sector to increase that rate by 1% across all care homes or across one care home? And they'll also look at what's the impact on health. So actually, are people going to hospital less? Are less people dying? Has it had that impact? Is there a reduced staff sickness? And then the final bit will be through the policy and dissemination working group, who will develop a policy document for commissioners looking at why this is important and what needs to be done to make sure that we can increase staff vaccination rates, and a toolkit for care homes on how they might put this intervention into place the next winter, which will be winter of 23-24, which sounds so far away. And that was a kind of whistle-stop tour of where we're up to with flu care, and hopefully the opportunity to see the beginnings of a research project as opposed to the findings, which is what you normally see. Did anyone have any questions?
Great, thank you so much, Alice, for kicking us off. That's been really interesting, very timely as well, as we know, vaccination and stuff. So you've had a few questions or statements in the chat box, but if you also have another question, please feel free to just add it or raise your virtual hand. So there's some comments from Simon and Claire. So Claire was saying, I've been thinking a lot recently about frustrations that can accompany research communication with people who don't want to hear about science. And I think also what you mentioned about celebrities advertising for vaccination, that, was an interesting point.
Larissa, can I put my question in, if that's all right? So I don't want you to read out my comment because it was just a glib one. That was all about a neighbour. But Alice, I that was an incredibly impressive project. I'm so looking forward to seeing how it all goes. I'm actually just currently recovering from illness, which is why I'm off camera. I'm not looking so good. But I have a slightly broad question, if that's all right. I mean, I have lots of specific questions too, but I'm just going to try and get the best one I can in, which is how has it been trying to organize a really complex research study, trial even, in a care home environment during COVID? Tell us all about that. That must have been very, very difficult.
Yeah, it's been challenging. I guess the biggest challenge has been trying to get the intervention developed, so getting the filming done, because that involves a whole film crew coming into a care home. Whereas actually for a lot of the intervention, we don't need to go in, and it's putting the emphasis on the care home. So can you send us this information? So it's slightly unnerving, I guess, because it's a very different way of doing it. Whereas normally kind of all the researchers would fly in through the doors and introduce a study like that. A lot of it's been virtual, and we've been getting expressions of interest sent to us via a kind of Google Doc questionnaire. So it's been very hands-off, whereas normally we'd want to get into the care homes and kind of be chatting about the study and introducing the people. So yeah, it's been quite a strange experience.
Have you had to delegate an awful lot more, as in because you're not allowed so many contact points? You're having to say, basically, you're just having to sort of drop the study off at the door and say, just do this. Is that how it's kind of gone?
Yeah, so they're still in the process of setting up each of the care homes as a site. So we're not entirely sure how successful that's going to be yet. But yeah, it is very much kind of, this is what we're going to be asking you to do over this period of time. And I guess what's a bit more unique about this study is because it's staff vaccination rates for the first bit, we don't need to consent any residents, because that would have been a huge challenge if we weren't able to go into the care homes, because obviously we'd need to spend time with the residents, get to know them, introduce ourselves. But for this first bit, we don't need that.
Okay, so you don't need consent to get outcome data for residents, is that right?
For the next bit, we will do.
Oh,
yeah.
Okay, fine, yeah. Sure.
But and then when there's the ethnography and the interviews, obviously we'll need to get consent from people. But for this first kind of setup bit, we'll just need kind of overall consent for the care home, and then each of the staff members who gets involved.
Great. So we've got another question here. Thank you, Simon, from Claire about, are you considering ethnicity of your participants, Alice?
Yeah, so this is something that came up when we put the grant application in terms of, well, everything really. So ethnicity, not only of the participants, but also our groups. So have we got an appropriate kind of mix of people involved in the lay advisory group, in our steering group, in the expert advisory group? So the NIHR really wanted us to kind of discuss at length why it was important that we had got ethnic diversity within our different groups. The challenge, I guess, with the participants is that it's the care home who's signing up, and we can only recruit the people who live in those and work in those care homes. We have specifically chosen 3 areas of the country where there are kind of different profiles of the areas, I guess. So we expect kind of Norfolk to have a very different profile to Leicester, and again to London. So that's why those 3 areas of the country have been chosen, in the hope that that will increase the diversity of our participants. Obviously this year with the 10 care homes as the feasibility study, that's one of the things we can look at, and we can then look when we recruit the 70 care homes next year, we can make sure that we're recruiting people appropriately.
Great. That's been really interesting. I'm mindful of time, and we've got lots more talks, but there's some questions for you in the chat, Alice, which you may be able to respond to whilst we have the next talk, if that's okay.
Yeah, I'll do that.
Great.
Thank you.
So thank you very much. So that's been a nice kickoff to this. And next one, we have Dr. Warren Donnellan, also from University of Liverpool, and he'll be talking about the preliminary development and validation of the Ecological Resilience Scale for Spousal Carers of people living with dementia. Over to you, Warren.
Thanks, Clarissa. It's a bit of a mouthful, I realise. Yeah, thanks everyone so much for coming and being here today. Yeah, so I'm a lecturer and psychologist in the Department of Psychology at Liverpool, as Clarissa said, and today I'm going to talk about the preliminary data and findings from this study where I'm developing an ecological resilience scale, and I'll tell you a bit about why that's needed and what we're hoping to achieve. So we know that caring for a relative or a friend living with dementia is uniquely stressful. And a number of research studies have looked into this specifically. And we know that relative to other groups of informal carers, so people looking after people living with other conditions, carers of people living with dementia are particularly stressed, they're significantly more stressed, and have poorer physical, mental health outcomes and other psychological impacts as well, such as kind of low self-efficacy and low subjective well-being, relatively speaking. And we also know that there's some evidence to suggest that caregiving stressors differ depending on the nature of the caring relationship. So it depends on who it is you're looking after. So most of my work has looked at spousal carers, which is kind of why I was starting off with this scale aimed at that group. And we know there was a review conducted by Etters et al. In 2008, I want to say, which found that spousal carers are at increased risk on a range of different outcomes, and the report being significantly more burdened. And that was explained in terms of those typically closer relationship ties that exist, which is associated with a sort of loss of companionship and reciprocity and communication. So dementia carers are an important group. Spousal carers in particular are an important starting point as well. Now, I'm very interested in resilience, and that was kind of the focus of my PhD. And I really wanted to do something in this area, and I've wanted to do something in this area for a while in terms of measurement. But in terms of what resilience is, it's a very intuitive term. Everyone has their own definition, but I like this definition on the left there. I'm not sure if you can see it too well, but there it is. This was produced by Jill Windle in 2011. This was based on a concept analysis of lots and lots of different articles that looked at resilience. And this is the kind of working definition that I use. So it's the process of negotiating, managing, and adapting to significant sources of stress or trauma. Assets and resources within the individual, their life and environment facilitate this capacity for adaptation and bouncing back in the face of adversity. So there's three key features there. You've got this sense of adaptation in some form, but really importantly, you've got this sense of assets and resources that are not just within the individual, not just a trait or a psychological phenomenon or a concept, but we're talking about community resilience here. We're talking about societal resilience. So it's moving away from this notion of a psychological resilience towards more of an ecological resilience. Now, care resilience is important because it wouldn't be the full story to say that carers were, exclusively, wholly, completely stressed by this. Most people, and there's evidence from people like George Bonanno, who's a really kind of famous resilience researcher, that actually when we encounter stress across the board, most people cope well. Most people are resilient. That is actually the norm. The norm is not trauma, the norm is resilience. So really there's an onus, and I feel a duty of responsibility to understand what that response looks like. And one of the benefits of looking at resilience, of course, is that as well as looking at protective resources, we do also look at the nature of that stressor as well. So it's more comprehensive. So yeah, there are individual differences in response to caregiving stressors. We know it's uniquely stressful, but many carers are resilient. That said, resilience is typically inconsistently defined and inconsistently operationalized. And what I mean by that is there was a review conducted by Windle, Bennett and Noyes in 2011, which found that really there's lots of resilience measurement scales on the market, but many of them lacked conceptual and theoretical adequacy, which means that there's a lot of differences and variation in what they said they're supposed to measure. And most of them look at this trait resilience, this psychological resilience, even though we know that resilience is as much about the environment, it's as much about the community and society as well. So there's a real need to take a more kind of social ecological approach to this, drawing on work like Bronfenbrenner and social ecological systems theory, so that we're actually addressing not just those traits, which are important, not just those psychological characteristics, but those community dimensions and wider socio-political sort of dimensions as well. And what's really exciting about this is that it would have theoretical and practical applications. So the aim really is to look at, you know, if we can measure resilience effectively on an ecological level, it would enable researchers to more accurately operationalize resilience. So we'd improve that definitional basis and we'd improve operationalization of resilience. And we'd be able to identify and characterize the factors that are associated with resilience. Because currently there's so many things that have been correlated and associated with resilience, and sometimes it's difficult to know where to begin. But essentially this would allow us to much more clearly delineate that and operationalize those factors. But practically, through identifying levels of resilience, it would potentially also enable people who work alongside carers to target support to those at highest risk. So there's a kind of risk versus resilience continuum here. And we know that people who are less resilient at a point in time will typically, on average, be more at risk than someone who's highly resilient. So it's not just about saying these people are highly resilient, great. It's about saying, okay, this is a continuum, identifying where people fall on that continuum, and then targeting support accordingly. And if we have subscales within that, if we use the ecological framework, if we have individual, community and societal factors or subscale scores, then you'd even be able to go a step further than that and say, actually, this person might be highly psychologically resilient, but might be slightly lower on a community resilience, which means actually what they need is more social support. So that's the aim. And this reflects, you know, this idea of care being tailored and personalised. So it's very much in line with those social policy recommendations. So the aim of the current study then was to develop and validate the ecological resilience scale for spousal carers of people living with dementia. Okay, this is a three-stage process, and I've put the dates there. Obviously, this was during the pandemic, although not in those kind of really early, very difficult stages. So back in July last year, we started this initial item generation, which is the first stage of any scale development. And then in August, we ran an expert panel to assess the items that we generated. And then we piloted this with spousal carers in September through December last year. And I'm going to basically take you through this process briefly, just to give you a sense of what we've done and how we've got to where we've got to. Okay. So as I said, the first stage was item generation. And this involved generating an initial item pool, and also looking at things like scale properties as well. So looking at time frame, looking at is it a frequency that we're going to be looking at? What kind of Likert scale structure do we want to use? And we did this using two different methods. So the first method was using some of my own qualitative data that came out of my PhD quite a long time ago now, but that's data with spousal carers. So I had longitudinal qualitative data that was conducted between 2011 and 2013. With 13 spousal carers were followed up, which is not a great, it's not a massive sample of people, but the richness and the quality of that data was very good. So it was ideal for this kind of activity. So we content analysed that data to generate items, and then once we'd done that, we also reviewed all of the existing resilience measurement scales that are in existence, including divergent measures as well. So not just resilience measures, but things like caregiver burden measures, burnout, depression as well, just to look at whether any of them could be flipped potentially. And then we just kind of triangulated those two methods. So we generated a 73 item self-report questionnaire with a 4-point Likert scale, which measured the frequency of individual, community and societal resources over the space of an average week. And this was very much based on the qualitative data from what people were telling me, what carers were telling me, and also what existing measurement scales were doing as well. So what we did then is we took this preliminary scale that had been generated, and I assembled an expert review panel. And the expert review panel was made up of 13 researchers, clinicians and carers of people living with dementia, not just spousal carers, but other carers, people looking after parents and other relatives as well, just to get diversity in there. And what we were interested in doing here was to assess the content and the face validity, as well as the scale design and presentation, just to see whether it was any good. You know, is it any good? Is it a load of rubbish? Let's just let's just pack it in now. And it was really quite, you know, really crucial stage in the process. So what we were doing was also looking at computer literacy checking and question understanding aid to make sure that the items actually made sense and that they were grammatical as well. So face validity was defined as relevance to resilience in dementia care. So how relevant is the item to this topic, to resilience in this group? And content validity was defined as how relevant the item was to the hypothesized construct. So if you've got an item that you're saying is under individual level, is it a truly individual level item? If you've got an item under the community level, is it a truly community level item? And we found that both face and content validity, based on the data that the expert review panel gave us, were both good. So it got a content validation ratio of 0.71 out of 1, which was kind of moderate. It was in the acceptable range. We also found that it was moderately easy to complete, so 6.85 out of 10, which is again not perfect, but again you'll see that we did subsequent refinements to improve that, and there were no issues with wording, syntax, or semantics, which is also positive, unless aged under the age, unless you're under the age of 13, because that's kind of how that question understanding aid worked. But obviously, the nature of this, the people that we're working with, no one's going to be under the age of 13, so that's good. And on the back of this expert review panel, 34 items were reworded, which sounds like a lot, but we were really trying to make these as good as they could be. 23 were added, so that's quite a lot to add, but that was feedback from the carers and the clinicians and the psychometricians, and 15 were removed, which were deemed kind of irrelevant or duplicating, and that was based on the qualitative feedback. So here's some examples of how that works. So this is an example of an initial item at the individual level, which was I do not dwell on things outside my control, which based on feedback we changed to I try to focus on things that are within my control. So it's about making that more positively framed rather than negatively framed. At the community level, we initially had I continue to express intimacy, implication, you know, being with my spouse, and that was changed to I continue to express affection, just to make that more specific. And then finally, at the societal level, this item wasn't changed. I'm able to use a respite care service if I need it, but we did add a not applicable option because some of the carers in our expert review panel were rightly telling us that this wasn't always necessarily applicable to some of the carers. So the final stage in the process so far was this pilot study. So by now, we'd actually increased the number of items, and I was well aware that this was far too many, but obviously this is the stage you've got to go through initially. So we ended up with an 81 item ecological resilience scale, and this was administered through Join Dementia Research, which is like a research recruitment platform. And it was administered to 50 spousal carers of people living with dementia across the UK. I think it was England, Scotland and Wales. So quite a good geographic spread. And we were now interested in really drilling down into the comprehensibility, the acceptability, and then to conduct some preliminary item analysis. So by comprehensibility, we mean how easy the items are to understand. By acceptability, we mean how easy the scale is to complete. And they were rated by the spousal carers. They filled in the scale as if they were filling in any scale, and then they completed a number of post-hoc questions, and this was one of them. So ERS was highly comprehensible, which was good. So the mean average was 8.59 out of 10. And the acceptability was also very good, which is 9.08 out of 10, which was good. So it was, you know, very easy to understand and very easy to complete. When we looked at some preliminary psychometric analysis, we found that the item endorsement frequency and homogeneity was both within the acceptable range. Endorsement frequency was looking at, again, it's a measure of how well an individual item loads onto a hypothesized construct. So is it measuring what you want it to be measuring? And homogeneity was how well the correlations between items. You'd expect that to be high. If we're all measuring the same thing, they should all be quite high. And that was both within the acceptable range. On the back of this, 7 items were reworded, 4 items were removed, and not applicable was added to 19 items where it was felt that a not applicable option was needed. And the time frame was actually also changed to average month based on feedback from the carers, which was just the changeability of care felt that actually reflecting on the average month would be much more appropriate. Interestingly as well, some items that did have poor endorsement frequencies, so kind of low Cronbach's alpha scores that were outside of the acceptable range, as you'll see in the next slide, were retained because we were recruiting during COVID, and we felt that some items were coming up with kind of poor statistics, basically because the services had closed. So I'll show you what I mean by that now. So hopefully you can see this. So at individual, community and societal level, I've given you some examples of what happened. So there was this item at the individual level, which was I take things one day at a time, and that had poor endorsement frequency, so that was removed. Similarly, I helped my spouse carry out tasks and take part in activities, was removed for the same reason. I go online to share my experiences with the caregiving community. That was removed partly because of endorsement frequency statistics, but also because it was duplicated. There was another very similar item which had kind of fallen off my radar, so that was removed. And then this, I'm able to create a safe home environment for my spouse and I. There was a huge ceiling effect there, because even if people weren't living in a safe environment, it was a self-report measure, and most people were at least claiming that there was a safe environment. So we felt that that wasn't an appropriate item, so we removed that as well. And these 4 items under the societal level, although they had poor endorsement frequencies, we did keep them because we felt that COVID was confounding the data. So respite care services had been disrupted at that point in time, as had daycare, as had cultural activities, as had work. So we've left them in for now, and if we feel like later on, based on the psychometric analysis, they need to be removed or tweaked, then we can do, but we felt like we want to leave them in for now. Okay, so I realise that's a lot. So just wrapping it up. So now we've got a 78 item ecological resilience scale, and that has been recently scrutinised by an expert psychometrician colleague of mine. And the aim is just to kind of keep refining it, reducing it, improving the item quality, improving the quality of the overall scale. And what the plan is for that then to be repiloted with a separate new group of spousal carers. So we're aiming for at least another 50 spousal carers to give us as much data as possible to make the scale as good as it can be. And then the idea is that the combined pilot data from last year and this year, and it'd be interesting to get that data as well, because obviously it's been a while since that first pilot wave was conducted, will then be factor analysed to confirm the hypothesised factor structure, to make sure that it is loading onto the factors that I say it is. And then it'll be finally re-administered longitudinally to look at how well it holds over time, to look at test-retest reliability, and then to also correlate it against convergent and divergent measures, which basically means measures that you'd expect it to positively correlate with. In other words, highly resilient people also tend to usually have high well-being, so that should be there. But also things that you'd expect it to negatively correlate with, so things like caregiver burden and measures of depression and stress. So as one goes up, you'd expect the other one to go down. And if that's not happening, then there's obviously something wrong, and we'd have to go back and fix that. And then concurrently with all of this, I'm also conducting a methodological review, which is a bit of an update on the 2011 review, to look at all of the resilience measurement scales that have ever been designed to look at dementia care particularly, or have been validated in informal carers, to see where this scale fits, basically. So at this point, I'd just like to thank you for your attention. I'd like to thank our expert panel for giving up their time, and obviously the carers as well. Just to acknowledge the funders. So it was initially funded by BPS undergraduate research assistantship last year, and more recently by Liverpool University Early Career Researcher and Return of Grant funding as well. And obviously no research is a solo effort, absolutely. So I'd like to thank my brilliant students, Amy, Rachel, Charmaine, and my colleagues, Jasmine, Paul, and Kate. There's my references. Thank you very much. And if you've got any questions, I'll be happy to answer them.
Thank you so much, Warren. That was really interesting. And yeah, so about a scale development, and we've got some questions in the chat box here as well. And if you have any follow-on questions, please just pop them in the chat box or raise your virtual hand. So one question from Claire, Warren, is could you explain what acceptability means in the pilot study?
Yeah, sure, Claire. Acceptability is how easy the scale is to complete. So how acceptable the scale is to the person completing it, essentially. And And that's always a concern, is obviously you develop these items for, you develop a load of items for grounded in good theoretical reasons, but you could administer it and it could be just not, it might not make any sense to real people. So obviously we got quite high scores in that respect. So yeah, so acceptability is how easy it is to complete, and comprehensibility is how easy it is to understand.
Great, and there's lots of questions now popping in, so let's go through them. One about cross-cultural adaptation from Anarita Sousa. Would cross-cultural adaptation of this scale make sense at this point? And given resilience and quality of life, have some items cultural specific meaning, or would this be interesting?
Yeah, it's absolutely on the radar. Resilience is obviously culturally bound. I'm terrible for running before I can walk, and I wanted to do everything with this all at once. But the plan is to validate it with spousal carers, because that's who I've worked with and that's where I've got the data. The plan is to then open that up and see whether it can be validated in other groups of people. So absolutely at that stage, that's where that would come online, and we'd be absolutely looking at how acceptable and how comprehensible it is to different groups.
Okay. And there's one question from Eddie Hoffman. I may have missed this, but are you distinguishing when you are engaging with a carer? For example, recently diagnosed, caring for 1 to 3 years, 3 to 5 years, etc.
Yeah, thanks, Edie. So the plan is, when we, at the moment, when we administer the refined version, when we look at those divergent and convergent measures, the plan is that we will administer it alongside a demographic questionnaire. And in that demographic questionnaire, you'll be able to specify your caregiving characteristics. So diagnosis, how long you've been caring for, et cetera, age, all of those variables that you'd expect to be correlated. And then when we look at the psychometric analysis, we can look at to see whether there are any patterns in those demographic trends. So yeah, absolutely, Edie, we'll be looking at that kind of thing.
Mm-hmm. And a question from Lauren about the psychometrics. Have you used the Rush measurement model or item response theory? So maybe for those people, because I am very aware that we have a large amount of people that are health and social care providers, so non-academics, and also lots of carers. So could you reply to that in a lay version, maybe, Warren?
Yeah, well, it has to be a lay version because I'm not a specialist myself. Lauren, I've got a fantastic colleague, Paul Christiansen, who's my psychometrician bod. He won't mind me saying that. And he's going to take the lead on some of the more complex analyses. So I couldn't answer that at the moment, but I'm going to absolutely hand over the data to him when it's conducted, so he can do his thing. But yeah, I'm aware of these kind of theories and models, but I wouldn't want to try and hazard a guess at the moment, because it's a work in progress.
Okay, and maybe one last question about resilience. I mean, that's your main area, or one of your main areas of research, isn't it? So I think someone's asking for data on helping carer resilience. Is there anything out there that you're aware of? I it's a good question. So there's a lot, as I said, resilience, there's been a saturation of resilience research. Some of it's better than others. As I said, there's a lot of theoretical inconsistency. There's some resilience interventions, again, some of them are better than others. But yeah, I mean, I'd be happy to discuss all of this further with any of you. If you want to get in touch, I'll put my email in the chat, because I think there's definitely more that can be done in terms of actually pathways to impact, and making sure that this doesn't just stay in some kind of academic ivory tower, and we're actually disseminating findings properly so we can actually help carers. I mean, that's what we're on the business of doing. So I'd be more than happy to discuss. If any of you have got any suggestions or suggested improvements or collaborations, I'd love for you to get in touch. So I'd happy to discuss that. Great, thanks so much. I think that was all of the questions. Thank you so much, Warren. Interesting, and I'm sure you have people to follow up with you about that work. The next talk is planned to be a pre-recorded talk from Dr. Kimberly Lazo from UCLan about oral care in older care home residents. Now, Kimberly is on maternity leave, so it's pre-recorded. Debbie, is it possible to share the video? You're on mute. Is it? Right, you're still on mute, Debbie. I think we're having some technical problems. So I would suggest we will see that later. Jack, would it be possible to move yours forward, and then maybe either we have Kimberly's pre-recorded after, or maybe Carrie fills in before the break. Is it possible to do yours now, Jack?
Just about. I nearly left for a cup of coffee, but that will be waiting for me. So yeah, I thought I'd come back just in case. You never know. So yep, sure.
Thank you.
Happy to do that. And because I'm not ready. Can you see that?
No, nothing shared yet.
Apologies. Let's go back again. Clarissa, I'm clicking on share screen, and I'm wondering, do you need to give me permission?
You should be a co-host, and there it is. Now it's appearing. Now we can see your screen with a little seal.
That was a seal that I saw in Whitby on holiday recently, and I was so taken with it. It's become my.
Right, over to you, Jack.
Are we there? Super. Thanks very much. And thanks, Clarissa, for giving me this opportunity to contribute. It's really much appreciated. I recognise I've only got 15 minutes, and brevity is not my strongest suit, but I will do my very best. And I know that the screens should be made available later, or if not, you can get in touch with me. You find an email address at the end of this presentation. I'll be happy to send them to you. First, I am not an academic. I'm not a dementia professional. My mum had dementia, and I was her carer for part of the last few years. And now my mother-in-law is living with dementia, so I have personal experience in that direction. But I'm also a dementia friends champion, trained by Alzheimer's Society, through which route I became chair of the Liverpool Dementia Action Alliance, and now also chair of the Liverpool City Region Dementia Advisory Group. Clarissa asked me to talk about Liverpool Dementia Action Alliance. Very happy to. I thought it might be good to speak about dementia-friendly communities as a broader topic. And then it occurred to me that it might be good to maybe combine the two. So that's what I'm doing, which means it'll be even more of a whistle-stop tour than would otherwise be the case. And so it's either going to be wonderful, like a combination of Simon and Garfunkel, or it's going to be a disaster like Boris and Rishi. We can see by the end of how we've got on. So Liverpool Dementia Action Alliance, to start with, well, what is it? Basically it's an informal group of organisations and businesses. It's not legally constituted entity. There's 339 local alliances currently in England and Wales, with 8,000 members between them. Liverpool Dementia Action Alliance started in 2013 after a very successful year of action on dementia here in Liverpool. And we, as of today, have 93 member organisations in total. BAAs are partnerships of public, private and voluntary organisations. They come together specifically to work together to pursue their common goals of helping people with dementia to live well. And that's the main thing they have in common. Otherwise, they cover every possible type of organisation and business. And also they want to make their communities places that are inclusive and supportive for people with dementia. The members of our own Dementia Action Alliance include big public bodies like the Liverpool City Council, the Clinical Commissioning Group, NHS trusts, other public bodies as well, like the police, fire and rescue service, passport office, which interestingly has been one of the more active agencies within the DAA. And every possible commercial business is also represented as well, from individual shops to major retail complexes, professional services, including legal, financial, architects, housing bodies. We have arts and entertainment organisations, sport and cultural bodies. We have houses of memories. You're going to be hearing from Carol Rogers later on as well. We have academic bodies, including the Liverpool Dementia and Ageing Research Forum, glad to say, faith bodies, care providers, social enterprises, support and advocacy groups. So every imaginable body, both private, public and voluntary, represented in DAAs. What do we do? Well, we get together quarterly, still online at the moment, to share news from each other, sometimes collaborating. And just this coming together in itself is a justification for the DAA. There's many excellent initiatives that have come about simply through the act of networking. We have 3 subgroups which focus on, one of them on minority culture and minority ethnicity, culture and community issues. I see amongst the audience here is Di Burbage, who chairs our diversity subgroup. We have a raising awareness subgroup, and the most important is SURF, the Service Users Reference Forum, which is comprised of with dementia and family carers. Hilary Tetlow will be speaking later, so I won't say too much about SURF, otherwise I might steal some of her best lines. That would be a kind thing to do. We have a coordinating group which carries out executive functions, and it does the coordinating. So what have we been doing? The activities that the Dementia Action Alliance have been involved in recent years includes running several very successful conferences for specific sectors. You see a few listed there. We ran a range of webinars as part of Dementia Action Week this year. We've created a not-for-profit company, Dementia Action Liverpool, to carry out contractual work, which the DAA can't do because it's not formally constituted. And that body was commissioned by Liverpool City Council and the CCG to carry out the research and consultation work necessary in order to produce the refresh of their joint dementia strategy recently. It was an excellent opportunity to engage with all of the stakeholders that are members of the DAA and beyond, and also critically those people living with dementia and family carers as well, which is the reason why we were commissioned. We've also carried out a wide range of support activities and projects to spread awareness and to help Liverpool towards becoming a dementia-friendly community, at which point we can talk a bit about dementia-friendly communities. Well, they focus on dementia-friendly environments as such can be traced back to Japan in 2004. And by now, 90% of OECD countries support initiatives of one sort or another to produce dementia-friendly communities. The UK joined the party in 2012 with the Prime Minister's Challenge on Dementia, which introduced targets for creating dementia-friendly communities, which were updated in 2015. But what does it mean, a dementia-friendly community? Well, the BSI code, as you can see there, some of the statements there say where people with dementia are understood, respected and supported, which I take that to mean that it's a place where where there's an obligation on other people to be aware of dementia, to appreciate, to accept, value and give respect and provide assistance to people with dementia. It does where people with dementia are confident and they can contribute to community life and feel included and involved. And I take that also to mean other people need to provide the opportunities for contributing and being included and involved, and to remove barriers. And finally, dementia-friendly communities are places where people with dementia have choice over their day-to-day lives, which of course is what everyone wants and expects. But society creates obstacles for people with dementia, as it does with other disabilities. So another viewpoint, and it's one I quite like, on dementia-friendly communities, is focusing on people, places and processes. So starting with people, when you think about whether a bus driver, shop assistant, solicitor, GP's receptionist, bank clerk, or a call centre phone operator, you need to understand dementia and the communication difficulties that it produces. People, and that's people, places and spaces, whether they're indoors or outdoors, need to be designed and constructed with dementia in mind. We can all think of examples of places which are difficult to navigate for everyone, even more so for someone with dementia. I think here in Liverpool, if anyone knows Liverpool 1, there's a shopping complex, and the signage and the difficulty of finding your way around there, it's even harder for someone with dementia. A very common example it's given is signage with toilets. Again, lots of us might have the experience of finding our way into a toilet and then not being sure how to find your way back out again. So signage in situations like that can be absolutely crucial. And processes, the way that organisations and systems work, can create barriers which need to be identified and removed. So I think that those three elements, people, places and processes, are a very useful way of looking at dementia-friendly communities. The process for giving dementia-friendly community recognitions managed by Alzheimer's Society, currently based on 10 characteristics and 7 criteria. In the process of revising their framework for dementia-friendly communities, and we're all looking forward to seeing how that comes out. There's 44 accredited dementia-friendly communities in northwest England alone, and Liverpool City region is hoping to become the first combined authority to become a recognised dementia-friendly community. I'm very pleased to be working on that. The characteristics, which are listed by Alzheimer's Society, won't go through these in detail, but I think the key phrases and words that come out is that a dementia-friendly community is a place where people listen to people with dementia, where we build awareness of the condition. It's a place that ensures inclusion, empowerment and engagement. It helps people to maintain independence for as long as possible. A place that removes barriers to independence and helps to develop responsiveness. Now, these characteristics are echoed in this alternative definition of a dementia-friendly community, encapsulating those ideas of empowerment, inclusion and access, integration, independence and participation. But maybe dementia-friendly is not necessarily the most helpful term. It's got a slightly patronizing feel about it. It feels a bit charitable. An alternative way of looking at it is the rights-based approach, which was slightly in the dementia statements of 2010, which included the statement that we have, this is people with dementia, have the right to continue with day-to-day and family life without discrimination or unfair cost, be accepted and included in our communities and not live in isolation or loneliness. So this is shifting the focus from people with dementia having a problem to the idea that it's wider society that creates problems and imposes barriers. And this is all what dementia-friendly communities is about challenging. So, rattle through that quite quickly. Concluding thoughts. But it's the responsibility of businesses, organisations and services to ensure that people with dementia are able to play a full part in the lives of their communities. And for this to happen, we need people, places and processes to change and adapt. Partnerships like Dementia Action Alliances can and do make an important difference by coming together and working together. And finally, and crucially, people with dementia and family carers need to be at the heart of decision making. They need to be heard and they need to be empowered to be actively involved as members of their community. And that concludes my talk. You'll see my email address there, so you can get in touch if you like a copy of these slides, if you're not able to get them otherwise. And certainly you'd be very welcome to get in touch if you or your organisation or business would like to become a member of Liverpool Dementia Action Alliance. Thanks very much.
Thank you so much, Jack. And the Liverpool Dementia Forum is actually a member as well, so that's great.
Yes, yes, I think I mentioned that, yes.
Yeah, and it's great to hear from something that really tries to make a change as soon as possible. I think sometimes with research, it's like we're researching, but it takes years for things to change. But really with the aim of the Liverpool DAA to trying to make it a dementia-friendly community in Liverpool is great.
Thanks for that. It's great having quick wins. It's great seeing real differences, and it is one of the challenges that we have is evaluating the actual difference that we make, the outcomes, not just counting the number of events that we have, the number of dementia friends are being created, but what difference has all this activity made? So there's a big piece of research to be done there, definitely. We're pleased to hear from people with dementia that there has been felt to be a change, a greater awareness locally than maybe in the past. So hopefully, yes, we are making that difference.
Definitely. And just one question from Ginger Lou. Is there a fee for businesses or services to join, Jack?
There is no fee at all. Something I skipped over is that all members of the Dementia Action Alliance, any Dementia Action Alliance, have their own action plans. It only has to be 3 actions. They have to sign up to say there are 3 things during the course of a year they are going to particularly focus on. And with that, they can become members of the Dementia Action Alliance. No fee whatsoever. Meetings that you can attend, contribute to, actions that you can take part in, support you can get on whatever activities you're looking for, and lots of information and help.
Great, thank you so much, Jack. And you see his email address here, but yeah, feel free to get in touch with him if you have any more questions. And there may be some questions for you in the chat box to answer as well, Jack, if you want to have a look at that.
That would be great. I'll do my best.
Thank you. So there's been some technical emailing in the background whilst Jack was giving his talk. Kerry, is it possible to share Kimberly's talk?
Yes, I'll put it up now.
Super.
Can you
Yeah,
see
we
that
can
okay?
Yeah, we can see the screen. Thank you. Yeah, that's great.
Good day, everyone. My name is Kimberly Lazo, and I am a research associate from the NIHR Applied Research Collaboration Northwest Coast. I am currently working for the Implementation and Capacity Building team based in the University of Central Lancashire. I would like to welcome you all to the 3rd Annual Liverpool Dementia and Aging Research Conference. This is such a great opportunity to see a broad range of health and social care professionals, academics, third sector organizations, and carers gathered in the same virtual room, where we can discuss our shared passion for dementia and aging. I am here today to present on behalf of my co-authors on the findings of our systematic review, looking at the impact of implementation strategies adopted in oral health interventions for older people in care home settings. The delivery of oral health care in care homes is something that is oftentimes overlooked, and that it is important for us to look at the existing evidence on how we could better improve the facilitation, delivery, and implementation of oral health for residents. So just a bit of a background as to what our study is about and why we think it is important. Good oral health is vitally important to both physical and emotional well-being of older people. However, those living in care homes are at greater risk of oral health problems. When older people have poor oral health, they may experience negative consequences on the overall quality of their lives, such as pain, difficulty in talking and eating, and social isolation. Care home residents often struggle to provide themselves with the oral care they require, which means staff are often required to do this for them. Carers are the gatekeepers to delivering oral care. However, research has shown that care home staff may not always give the most ideal mouth care to residents due to a lack of knowledge, skills, and/or confidence. It is often overlooked that carers experience highly stressful workloads with frequent interruptions while carrying out caring duties. Studies have shown that carers actually have 3 minutes on average to perform each task in order for them to complete all their daily activities. Because of this, there is a higher rate of reduced job satisfaction and burnout among carers. More importantly, there are also difficulties in accessing dental services by care home residents, including finding a suitable transportation and availability of a carer to accompany them. All of these highlights the disadvantages that exist for carers and residents, leading to oral health inequalities. In order to address this, evidence already suggests that there is a distinct need to integrate oral health with other general health interventions to increase its prioritization within care homes. Educational interventions and oral health promotions are already commonly applied in most care home settings. However, in order to effectively increase the impact of the interventions, we must also look at the implementation strategies and how they are tailored to the individual needs of care home settings. This involves solutions such as the use of oral champions, training for carers, more collaborative working across multi-agencies involved, and increased awareness and promotion of good oral care. That being said, the aim of our review is to examine which implementation strategies contribute to improving health outcomes of residents and changing the attitudes of carers in delivering oral care. More importantly, we want to understand the wider determinants of health and their impact on the adoption of oral health interventions. We must consider the health inequalities of carers, particularly those residing in low socioeconomic areas with lower education attainment and those that require training for their role. Lastly, this review wants to explore the barriers and facilitators to implementing oral care interventions in care home settings in order to investigate challenges to implementation. In order for us to achieve these aims, we are utilizing 2 implementation science frameworks, namely the Theoretical Domains Framework and the Consolidated Framework for Implementation Research. This is used to identify future solutions in implementation. Specifically, we will also be focusing on the capability, opportunity, and motivation constructs from the behavior change wheel to map the barriers and facilitators to implementation. So why did we decide to use implementation science as our key overarching method? In oral health research, it is already common to look at psychological approaches aimed at changing behavior. However, oral health uses these individualistic behavior change models and theories to underpin interventions designed to change the behavior of an entire population, assuming that one size fits all. They do not acknowledge things like carer input, organization, policies, and individual differences that exist within the respective care home settings. It is therefore recommended that we look at the mechanisms that contribute to implementation change so we can recommend tailored strategies for future use. Using implementation science frameworks will allow us to identify those mediating factors that influence behavior change, track the implementation process, and investigate the challenges to implementation. After conducting comprehensive searches in academic databases, we have identified 15 papers that investigated the effectiveness of oral health interventions for older people in care homes. Improvements were recorded across all outcomes, suggesting that there is a positive association between the interventions and improvement in oral health of residents and knowledge and attitudes of carers. We then used the CIFER to categorize the implementation strategies. The most notable strategies were the creation of a steering group with local stakeholders in the planning stages, combined with gathering of information through evidence-based planning. When engaging with stakeholders, some studies used oral health champions, while others engaged with the stakeholders through co-production. A variety of strategies are used in terms of executing the oral health interventions, such as face-to-face seminars, skills instructions, and hands-on demonstration. Only one study has used critical reflection in the evaluation stage. We then used the theoretical domains framework and the COMV model to identify the barriers and facilitators to implementing oral health interventions within care home settings. Our findings show that delivering good oral health was primarily driven by three key factors: carer knowledge and individual characteristics, health inequalities, and organizational priorities. Under capabilities, our review shows that the majority of the oral health interventions used training and educational components in order to increase knowledge and care characteristics. However, there was still a lack of understanding on how to enable the carers to learn the skills that they need. The findings propose that a multifaceted approach to oral health intervention, where a combination of strategies will be used. This includes establishing working groups, delivering interactive training sessions, distribution of resources, and critical reflection. Our second theme shows that opportunities can be identified to help improve carers' delivery of oral care. This is usually influenced by environmental factors, such as carers' attitudes to residents' poor hygiene and challenging behavior, which leads to the reluctance to carry out oral care. This is present in care homes where there is high staff turnover and lack of time and opportunities to undertake oral care. Carers come from various countries and cultures and may have different views on the importance of oral care and how it should be undertaken. Age can also be a factor, when some carers aged 55 and over actually find the job physically demanding, while younger carers are less knowledgeable on how to clean dentures or provide oral care for residents. In order to address such inequalities, empowering carers is encouraged in order to improve their attitudes towards delivering oral care. This can include informal discussions, gentle reminders, overseeing, supporting, and encouraging residents and family members. Finally, motivation for carers are usually influenced by the presence of strong leadership and additional support. These usually involve trainers taking the role of oral health champions and supporting staff to improve their practice through increased visits within the care homes. Another barrier to motivation is the lack of strategy and inconsistency in care plan documentation. With competing demands placed on care homes and carers, there is a tendency to have poor workload management and irregular updates on oral care plans. This silo working makes it more difficult for oral health interventions to be prioritized. So what are the implications of our findings? We know that there are still challenges in the delivery of oral health interventions, particularly in sustaining good and effective practice. Using both the TDF and CFR to bridge the critical gaps have allowed us to identify which strategies are needed to overcome the barriers, as well as providing solutions to improve future implementation practices. This review emphasizes 3 key things. First, there is a need to consider oral health to be integrated within other oral health interventions to increase its prioritization within care homes. There is still a tendency for clinical approaches to dominate the implementation of oral care policies and interventions within care homes. We need to change the narrative of the top-down, more generic approach to a bottom-up strategy supported by good leadership and managerial support. Second, the design of oral care interventions should consider the health inequalities that exist in delivering oral care. We know that older people in care homes are classified as vulnerable individuals and are less likely to receive routine care due to various social determinants of health. This means that carers may not be aware that they are not engaging in good oral health activities and may not even be aware of the oral health resources and opportunities that are available to themselves and the residents. Future studies must carefully consider these factors when designing interventions. Lastly, there is a need to engage consistently with key stakeholders to collaborate and provide additional support before, during, and after the implementation process in order to ensure sustainability of effective practice. Bespoke approaches tailored to the individual care home needs must be considered, such as co-production and collaboration in all stages of implementation. Thank you for listening to this presentation. If you have any questions or comments, please do contact me via email.
Thank you, Kerry, for sharing that. If we can just leave the slide up for just 1 second. So Kimberly is now on mat leave, but if you have any questions about this, so our systematic review will be submitted in the next couple of months, and then it might even be on preprint. But I hope if you have any questions, maybe drop an email, she'll pick it up when she returns. But also you can follow her on social media as well. And I think just maybe to summarize, it's Kimberly's great talk has highlighted that oral healthcare and care home residents seems to be really often neglected, but it's a really important area of health and well-being. So that shouldn't be neglected, really. Thank you, Kerry, for sharing. That's been great. So now we've got about a 10-minute break. So get yourself a cup of tea or something. And then we have 4 talks, which Kerry will start off then on post-stroke vision impairment and inequalities. So yeah, we'll have a 10-minute break now. Thank you very much. See you in a few minutes' time.